Good day, friends, and a warm welcome to 4D, that is Detailed Discussion and Dialogue in Indian Diabetes. A warm welcome to our show, Season 2, Episode 11. Now, 11 is a very strong number. 1 plus 1 can be 2. It can be seen as 11, but the strength that we have in 11 is something that we'll explore over the next half an hour or so. A warm welcome to our expert speaker, Dr. Alankar Tiwari. Warm welcome, Dr. Alankar.
Thank you so much, sir, for the kind introduction. It's a pleasure to be here. It's an honor for me to be here with you and discussing for today's session.
The honor is ours. Dr. Tiwari is one of our most dynamic endocrinologists. Studied at the prestigious medical colleges, the government medical colleges in Prayagraj and in Meerut. He is now social media advisor, social media expert for the Endocrine Society of India. He is also president of the IAPEN, which is Indian Association for Parental and Enteral Nutrition, the UP chapter. And he combines the art and science of endocrinology, of diabetology in a very beautiful manner. Dr. Alankar, we'll be speaking today about the kidney, chronic kidney disease and diabetes. But I'm reminded of this Bhojpuri song where the singer says, he sings to the lady, his lady love, either you give me your heart, or if you can't do that, at least give me your kidney so that I can become rich. So, what is the role of the kidney in our culture? Do we focus more on heart disease or on kidney disease? What do your patients speak to you about?
So you can understand the importance of kidney by the song only. That in place of heart, he is wanted the kidney also. So the importance of kidney is almost equal as compared to the heart in our body, and any damage to the kidney also reciprocates or also initiates or increase the cardiovascular mortality morbidity also. So kidney is very, very much important to us, and we all know that diabetes has now become the largest contributor to the chronic kidney disease in India as well as in world.
In diabetes, earlier we had a glucocentric approach. That was the best possible approach 2 or 3 decades ago, based on the evidence that we had at that time. We then realized that we were maybe going the wrong way, and we started thinking about the heart. But from one tubular vision, which is glucocentric, we moved to another tubular vision, which is cardiocentric. And many a times in modern science, in our discourse, we tend to view the kidneys as poor cousins of the heart. So, would you like to set the record straight, Dr. Lankar? We look forward to listening from you today.
Yes, sir. Because even earlier it was not much into the consideration regarding the organoprotective effect. We were more focused on the glucocentric focus. Even now, even in many centers in peripheries and all, the treatment approach is mainly now glucocentric also. In our day-to-day practice also, we are seeing that most of the GPs and all, they are focused more on the glucocentric approach, and patients also, they are also very relaxed if the glucose numbers is below 200 and all, they are much relaxed, is glucose to theek chal raha hai. But so organoprotective effect hai, that is not taken much into the consideration even now. So we all must I think create the awareness among the patients also, as well as the treating physicians and GPs, regarding the organoprotective approach in patients of diabetes, because for the long term better quality of life and longevity, we need the proper functioning of the organs also.
Thank you, Dr. Tiwari. And we look forward to listening to you. Doctors from across the country join 4D. And like we said, it's a detailed discussion and dialogue. So we look forward to listening from you. And then we'll have lots and lots of questions from doctors across the country for you.
Sure, sir. With your permission, I'll start my session today. So today we are going to discuss about the diabetes and chronic kidney disease. So the chronic kidney disease, which is due to diabetes and not any other cause, is labeled as diabetes kidney disease (DKD). So today we will see about the diabetes in India. The scenario of diabetes in India, we all know that India is becoming the hub of diabetes, and it is currently at second position in the world as the number of patients of diabetes living with diabetes in India is considered. The prevalence of diabetes is around 9.6% among adults aged above 20. And in India, among in every 11 adults, one is living with diabetes, and over 53.1% of the adults living with diabetes are still undiagnosed, which is a very alarming figure. So 90 million adults are currently living with diabetes in India, and among those, one in every two adults with diabetes are still undiagnosed. And 747,000 deaths are attributable to diabetes in year 2021. So we can well imagine the gravity of the situation, the alarming situation at which we are moving as the number of diabetic patients of India is considered. Now, diabetes and CKD, as we have discussed, that diabetes has become the most common reason, the most common cause for the chronic kidney disease. It contributes around 44% cases of CKD overall. The next most common culprit is high blood pressure. And we have already discussed in our previous sessions, like diabetes and blood pressure are like cousins and they go hand in hand. And mostly they are present together simultaneously in most of the patients of diabetes. So it further aggravates and increases the chances of chronic kidney disease in these patients if not taken care of diabetes as well as the high blood pressure. This is a mechanism of action, mechanism or pathophysiology behind development of CKD in patients of diabetes. Hyperglycemia or increased blood glucose levels, they affect the glomeruli and increase the angiotensin and angiotensin convertase enzyme levels, which further increases the angiotensin second. It increases the albumin excretion in the urine, which can cause further leads to chronic kidney disease. It also increases the single nephron GFR. So the first pathophysiological mechanism which occurs in a diabetic kidney disease is the hyperfiltration, hyperglomerular filtration. So there is proximal tubular growth and there is increased SGLT2 expression. And through this co-transporter of SGLT2, there is increased reabsorption of sodium as well as glucose from the proximal convoluted tubule, which further adds to the hyperglycemia. In proximal tubule, there is also increased messenger RNA and renin production as well as angiotensinogen production, which further increases the angiotensin 2, which causes increased tubular reabsorption of sodium. And this increased reabsorption of sodium, retention of sodium, it contributes to increased extracellular volume and which ultimately increases the blood pressure. So all these factors, increased albumin excretion, hyperfiltration at the level of glomeruli, increased extracellular volume and blood pressure, they further contribute to the progressive kidney disease damage. And hyperglycemia itself is causing the endothelial damage, oxidative stress and all. So all these factors they together causes the diabetic kidney disease. So, chronic kidney disease it is a progressive, irreversible loss of kidney function, and it is defined as the either presence of kidney damage, either pathologically abnormalities are there, like hyperfiltration, the basement membrane thickening, and then the glomerular sclerosis, or decrease in glomerular filtration rate less than 60 for the persistently for the next 3 months. Also, excretion of albumin through the urine. If it is between 30 to 300, it is labeled as microalbuminuria. If it is more than 300, it is labeled as macroalbuminuria. It can be go hand in hand, like increased albumin secretion from the urine as well as decrease in the glomerular filtration rate. Or it can also happen that both can be present alone. Either one of them can be there together also in the patients of type 2 diabetes. So if it persists for at least 3 months, we can label the patient as chronic kidney disease. This is the classification of the CKD patients and staging of the CKD patients based on EGFR as well as the albumin excretion in the urine. So CKD is classified based on the GFR. We have divided into the G1, G2, G3A, G3B, G4, and G5 stage. G1 is normal when the EGFR is more than 90, while G5 is the end stage renal disease when the EGFR is below 15. And similarly for albuminuria, we have A1, A2, A3. In A1, the albumin excretion is less than 30 milligram per gram, as well as in A2 there is 30 to 300, and if it is more than 300, we label as A3 or severely increased albuminuria. And combining these staging with albumin as well as EGFR, we stratify the risk of the patient regarding going into the end stage renal disease. Now, who and when to screen? What are the groups of patients who should be screened and when? So we know that there are mainly two types of diabetic patients with us. One is type 1 diabetes and the second one is type 2. Type 2 is more common. In type 1 patients, the after time of diagnosis, we should screen the patients for kidney disease at least 5 years after the diagnosis. While in type 2 diabetes patients, we should screen at the time of diagnosis itself. Now, how to screen? We can have a spot urine ACR. It is a very easy and very convenient test which can be done at even in the OPD basis. And another one is measuring the EGFR level, which is measured by the creatinine clearance. And now, what to do with a positive result? If a patient comes with a positive result with this spot urine ACR or EGFR, then we can repeat and confirm, evaluate possible temporary or spurious causes for them, consider using cystatin C or other markers of renal injuries, and more precisely of creatinine GFR measurement. And if there is persistent abnormalities in decline of CKD, then we can label patient as the CKD. And what declines CKD diagnosis? What defines, as we have discussed, that there is persistent decrease in the EGFR for more than 3 months, or there is persistent urine ACR more than 30, or both of them together, or other evidences of kidney damage. We have other markers, newer markers like cystatin C, neuroglin 4, or kidney injury markers, etc. So now, what are the therapeutic strategies for diabetes management? Diabetes management in patients who are at risk of developing kidney disease or are having kidney disease, how to manage blood glucose levels and also protect the organ in these patients. Because as we have said, as the sir has said, like now we are moving from the glucocentric approach to the organoprotective approach. So we don't focus just on the numbers of blood glucose level. We also focus on halting the progression of various organ and preventing the end organ damage, various macro as well as microvascular complications of diabetes. And we all know that early initiation of combination therapy or intensive therapy is the key to achieve the glycemic control in patients of diabetes. And any delay in initiating the treatment can deteriorate the glycemic control as well as cause the damage to end organs, because we know that there is a term called as memory effect or legacy effect. If there is the bad control, poor glycemic control in initial period, that the body, the cells remember it for a very long time and can make the changes like that only. So we should focus on creating a good glycemic memory and have a very early intensive control with combination therapy. Now we have very novel medication therapies and FTCs which are with us, which are very good in controlling the blood glucose levels as well as preventing the organ damage and other having the pleiotropic benefits like cardiovascular benefits, renal protection, and others like. So these are used with along with diet and exercise, because we all know that lifestyle modification is the first and foremost management therapy for the patients of diabetes. So apart from lifestyle modification to control high blood glucose levels in patients of type 2 diabetes, these groups are DPP-4 inhibitors like sitagliptin, linagliptin, alogliptin, SGLT2 inhibitors like canagliflozin, DAPA, and empagliflozin, and GLP-1 receptor agonist like liraglutide, dulaglutide, and semaglutide. So DPP-4 inhibitors, they actually decrease the breakdown of GLP-1 and GIP-1 incretins So they enhance the insulin secretion and action by incretin effect. And also they stimulates insulin secretion from beta cell. They decrease the glucagon secretion from alpha cell. They are weight neutral and have a very low risk of hypoglycemia. So they are very safe group of drugs. While SGLT2 inhibitors, they are very the latest addition to the armamentarium of diabetes drugs. They inhibit the SGLT2 co-transporter which are present in the proximal convoluted tubule and inhibits the renal reabsorption of glucose. So they work independent of the insulin level, and they cause the excretion of glucose through the urine. And they decrease the glucotoxicity in body, and also cause as the decrease in the systolic as well as diastolic blood pressure. And one additional and very important benefit of these group of drugs is that they also cause weight loss and also has a very low risk of hypoglycemia. So the combination of SGLT2 inhibitor and DPP4 inhibitor uh, in patients of Indian diabetic patients are very important and a very suitable option because of the following reasons. Like they are safe, rapid, and have a sustained glycemic control. They improves both the insulin resistance and beta cell function. They help reduce body weight and blood pressure, which are the extra glycemic effect or pleiotropic benefits of these drugs. And obviously they have a very they reduce the pill burden of the patients, which increases the adherence and compliance, because in Indian scenario, it is very Indian or worldwide scenario, the patient wants to take minimum amount of medicine. Whenever patient comes to us, he just say, doctor sahab bahut kam dawa likhega, jitni ho sakti hai kam likhega, and also cost effective. So it reduces the pill burden and the bill burden of the patient. Now, SGLT2 inhibitor and DPP4 inhibitor in diabetes management, what the studies and trials say. So, dapagliflozin in combination with sitagliptin, it was well tolerated in the various studies, and it led to clinically meaningful reductions in glycemic parameters and body weight that were sustained through 48 weeks of treatment. So this study was conducted over 48 weeks, and it was seen that the combination of DAPA 10 milligram with sitagliptin, it causes the uh, more reduction in HbA1c from the baseline as compared to the placebo and sitagliptin combination. Now, this is a synergistic combination. The combination of SGLT2 inhibitor and DPP4 inhibitor is a synergistic combination. They act in a synergistic way to cause the glucose control as well as protection of various organs in the body. SGLT2 inhibitor, they increase the urinary glucose excretion, so does decreases the glucotoxicity, decreases the plasma volume, and it acts through the kidney and also cause a renoprotective effect. Thus decreases the cardiovascular risk, because we all know that kidney damage as well as increased albuminuria is an independent risk factor for cardiovascular mortality. So it decreases the cardiovascular risk factors, decreases the body weight, serum uric acid, as well as reduction in blood pressure. It also increases the beta cell sensitivity and decreases the insulin resistance, and increases the glucose, hepatic glucose output and glucagon secretion, which is counteracted by the DPP4 inhibitor. DPP4 inhibitor decreases the hepatic gluconeogenesis and secretion of glucagons from the alpha cells. So these two actions are balanced of SGLT2 and DPP4 inhibitor if they are given together as an FDC. Then DPP4 inhibitor is also increases the insulin secretion through incretin effect with GLP-1 and GIP-1 incretins. It also causes the renal vascular oxidative stress, decreases the oxidative stress, as well as increases the endothelial function. So they act on kidney, gut, and pancreas. So acting on these three organs, they cause the reduction in hyperglycemia, albuminuria, serum uric acid, blood pressure, as well as there is very low risk of hypoglycemia. SGLT2 inhibitor decreases body weight, while the DPP4 inhibitors are almost weight neutral. So this combination is like a synergistic combination and it is a very effective as terms of health benefits and benefits regarding the patient, like financial benefits and the compliance benefits. These are some of the benefits of SGLT2 inhibitor. For the liver, they utilize the non-esterified fatty acid. They increase hepatic glucose output, decrease ketogenesis, and decrease the steatosis. Some of studies, they have proven the role of SGLT2 inhibitor in cases of NASH and fatty liver disease. And they causes the glucosuria and natriuresis. So on pancreas, they increase the glucagon secretion. They decrease the glucotoxicity by causing the urinary excretion of glucose and thus weight loss also. In kidneys, they improve the restore the tubuloglommerular feedback, which was disturbed due to the hyperglycemia. And they also decrease the oxidative stress, decrease the fibrosis, which was keep going on the glomeruli. Glomerular sclerosis is a very pathognomic feature of diabetic kidney disease. They also increase the diuresis and also increase the uricasuria, uric acid secretion from the urine. In cardiovascular, they decrease the arterial stiffness, decrease the plasma volume, and thus decrease the blood pressure. They overall improve the endothelial function of the heart and also decrease the congestive heart failure and hospitalization due to heart failure. So, in various trials like DAPA CKD, Declare TIMI 58, and DAPA HF, it has proven its benefits in cardiovascular mortality as well as in DAPA CKD. It was found that the when dapagliflozin was compared to the placebo, it has shown improvement in EGFR. Less decline was shown with EGFR when dapagliflozin 10 milligram was used. Both patients with type 2 diabetes, in type 2 diabetes with CVD or non-CVD. And similarly, in DAPA HF trial, it was shown that it has benefit in patients who have having the congestive heart failure and decreases the hospitalization due to heart failure in those patients. For lipids also, it decreases the fat mass, increases the lipolysis, and increases the free fatty acid utilization. So with all these benefits, it is a very wonderful drug and has helps on various organs which are affected by hyperglycemia in patients of diabetes. Now, what the evidence-based studies they say about the dose adjustment in CKD patients? So, for chronic kidney disease patients who are diabetic, so we will go with the HbA1c criteria wherever is applicable. So, SGLT2 inhibitor, they can be given if it is EGFR is more than 25, and the dose is dapagliflozin dose is 10 milligram per day daily, and initiation is not recommended if EGFR is below 25, but may be continued in some patients who tolerate for kidney and CV benefit until they are going for the renal replacement therapy like dialysis and all. And sitagliptin, we should choose the gliptin which is renal safe. And if it is, we are using sitagliptin in patients of CKD, if it is the EGFR is less than 45, we should reduce the daily dose of sitagliptin to 50 milligram. If EGFR is less than 25, then we should make the dose to 25 milligram once daily. And because with the lower EGFR, the glucose lowering efficacy of SGLT2 inhibitor it decreases, but the effect of on kidney and cardiovascular benefits they are still preserved. So continuation of SGLT2 inhibitor are advisable in those patients even with a lower GFR. Dapagliflozin is approved for use of at least 10 milligram once daily with an eGFR of 25 to less than 45 ml per minute per meter square. Now, holistic approach for patients with diabetes and CKD. So it is very important. And what are the factors? What are the pillars for the diabetes management and organ protection in patients of diabetes? So lifestyle management comes very first of all with healthy diet, physical activity of at least 30 minutes per day, smoking cessation, and all kind of addiction cessation, and weight management. Then first line drug therapy is like SGLT2 inhibitor if it is more than 25, EGFR is more than 25, metformin if eGFR is more than 45 or between 30 to 45 with reduced doses, regular assessment of glycemia, blood glucose levels, albuminuria, blood pressure, cardiovascular risk assessment, and lipids levels. Then, if there is need of additional risk-based therapy, we can go for GLP-1 receptor agonist if needed, or other glucose-lowering drugs if needed to achieve the individualized glycemic target. Then other like RAS inhibitor at maximum tolerated dose if patient is also hypertensive. And we have other non-steroidal mineralocorticoid receptor antagonist like fintrinolone if ACR is more than 30 and patient is having normal potassium. This can also be considered. Other dihydropyridine calcium channel blockers or diuretics can be added to achieve the target blood pressure levels, or other steroidal MRA if need be, if EGFR is more than 45. Moderate to high intensity statin therapy can be considered as per the ASCVD risk assessment, antiplatelet agent for the clinical ASCVD, and other drugs like ezetimibe, PCSK9 inhibitor, or icosapentine ethylene can be indicated based on the ASCVD risk factors and lipid profile. So this is the treatment algorithm or approach, holistic approach for the patients of diabetes who are also having the kidney disease. And one thing is very important, that regular risk factor assessment for every 3 to 6 months is advisable. So regular follow-up with patients and counseling is very important for the patients. So that's all for the day. Thank you so much.
Thank you, Dr. Alankar. Wonderful talk, very well presented. And we have lots of interesting questions. First of all, lots of compliments coming from doctors, thanking you for how simply you've elaborated on such a difficult topic. One question is, when we speak of SGLT2 inhibitors as nephroprotective, can these replace other renoprotective drugs? For example, ACE inhibitors or ARBs, or are they to be used in combination?
Sir, as we are using ACE inhibitor, if person is using ACE inhibitors or ARBs from before, regarding the if patient is also having hypertensive and all, so ACE and ARBs have their own benefits regarding the blood pressure control and renoprotective effect. But this dapagliflozin is also has various other benefits like control of blood glucose levels, cardiovascular benefits, and renoprotective effects. So it can be added over these ACE inhibitors and ARBs if the patient's blood glucose levels are not well into the control. So they have their own space and benefits, while the ACE and ARBs have their own benefits.
One question coming from a doctor in Madhya Pradesh is, sir, can we prescribe these simultaneously? So patient comes to me today, patient has type 2 diabetes, is uncontrolled, and there is a need for renoprotection. So can I give an SGLT2 inhibitor like dapagliflozin along with ACE inhibitor or ARB simultaneously, or do I have to add sequentially?
So as we have discussed about the risk stratification and staging of the CKD, so we have to stage the patient according to based on their EGFR and albumin excretion UACR. So in whichever stage the patient falls, then we will decide the treatment accordingly. If patient is already on the ACE inhibitors or ARBs, then we will monitor the serum potassium levels and then the doubling of the EGFR and creatinine levels. Then we will decide about the stopping or continuing the ACE inhibitors or ARBs. And for the dapagliflozin, we have discussed that if EGFR is more than 25, then we can start the patient on dapagliflozin, seeing the other benefits of dapa like controlling the blood glucose levels and other cardiovascular benefits also. So it can be started simultaneously as per the risk categorization and staging of the patient CKD.
When it comes to fixed dose combinations, one very popular combination in the country is dapagliflozin and sitagliptin. So would you like to speak about this? What are the EGFR cutoffs for the thresholds for initiating the treatment? Is there a threshold for discontinuation?
Yes, sir. The threshold is below 25 to 20. Recently, they are coming to 20. Some studies have also told about the 20 EGFR patient. So it could be given up to 20 EGFR, dapagliflozin. Sitagliptin can be given safely above 45. If EGFR is falling below 45, we have to reduce the dose of 100 milligram per day to the 50 milligram per day. And if it is falling more than 25 ml, then we have to reduce further to 25 milligram per deciliter. So we have to reduce the dose of Sita as well, sitagliptin. If EGFR is coming below 20, then we have to stop the DAPA also, or patient is moving to hemodialysis.
A question from one of our colleagues is, and she points out, and rightfully so, I think, sir, in theory, all these drugs are easy to use, but practically, I have patients who don't come back to me for regular follow-up and for regular RFT. Overall, is dapacetalgliptin a safe combination to use in case the patient is not going to come back to me for the next 6 months? And what are the counseling tips? When should I tell the patient these are the red flags? You must come back to us if you experience any of these symptoms.
Patient must be counseled well before. Whenever the patient comes to us, we should be counseling the patient for the follow-up, especially in all the patients. And if it is not coming, we have to tell the patient about the regular monitoring of blood glucose level, that is called as the self monitoring of blood glucose levels. Then should be aware from the some symptoms like urogenitary infections. If patient is having any kind of urinary tract infection or mycotic genital infections, any itching around the genitalia, then he or she must be aware and tell or inform his or her doctor also. So, and then also in summers, like in summer seasons, if we are using these drugs, or if patient is keeping any fast, especially the nirjala fast and all, when we don't take water at all, then even that time also patient should be aware regarding the use of that drugs, because in some patient it is seen that it might be causing the euglycemic diabetic ketoacidosis also. So patient should be make aware of the blood glucose levels. It should be not to be given should not be going to the hypoglycemia as well as the hyperglycemia, infections, UTI infections, genital mycotic infections, and these ketoacidosis. So patients should be counseled about these things before starting the medications, FTCs.
A very challenging question, and this is, sir, we have many patients with diabetic kidney disease. Now, we do our best to manage them. Some of them remain stable for many, many years. The creatinine goes up slowly, the EGFR comes down slowly. Overall, they remain stable. On the other hand, there is a small subset of patients who worsen so rapidly in front of our eyes. We keep on adding therapy, we do our best, but they slip into end stage kidney disease very fast. So, how do we predict in the OPD? Are there any biomarkers, any symptoms, signs, surrogate markers which will help us identify the patients who are at high risk of rapid worsening? And how can we help them?
See, high risk patients are like the risk factors are already there are some genetic factors also, the and some non modifiable factors like age, ethnicity, and male preponderance also for the CKD. But the risk factors which we can keep watch or we can modify is like the blood sugar levels. If patient is having very fluctuations or excursion in blood glucose level, is not having a proper blood glucose levels, and blood pressure also, because if blood pressure is not under control, it also contributes to the or aggravates or expedites the progression of CKD. So, and along with this use of other some drugs like which are nephrotoxic drugs, or some other alternative medicines which we are not aware of what it contains, some like Ayurvedic or whatever formulations they are using. So because many patients are there which who are along with our medications of diabetes, they are simultaneously using the Ayurvedic and other churn and powder and syrup, and after that they tell that डॉक्टर साहब मैं तो ये भी खा रहा था साथ में और ये भी पी रहा था. तो बहुत से ये भी फैक्टर्स होते हैं जिनका भी साथ में ध्यान देना चाहिए कि पेशेंट हो सकता है साथ में कुछ और भी चीजें ले रहा. एंड फॉर दीज पेशेंट्स हु आर हाई रिस्क, लाइक दोज पेशेंट्स हु आर एल्डरलीज, दोज पेशेंट्स हु आर हैविंग सिंगल किडनी, दोज हु आर any history of renal transplant or CKD in their family, whose blood glucose levels are not well controlled for the past few years, and those who are also having high blood glucose levels, taking a number of medications, especially painkillers and NSAIDs, So in those patients, we should counsel them to measure their blood markers of the CKD, like creatinine, UACR, very frequently, at least 2 3 to 6 months, so we can catch them up very early and try to halt the progression of this CKD in those patients. So we have to
Subs-
segregate triage, make a triage for these type of patients and counsel them repeatedly.
Substance abuse, like use of tobacco in various forms, uh,
Uh,
pan chewing, betel nut chewing, are these
Very good.
also associated with the worsening of kidney disease?
Banaras, Banarsi Pan, sir.
So, what message would you have for people who are contemplating whether to start eating pan on a regular basis, maybe 10 times a day, or to begin smoking? What message would you have for them?
नो सर, नॉट एट ऑल, नॉट एट ऑल. मतलब आई तो मैं तो हमेशा ये बोलता हूँ कि पान भाई ठीक है, बनारसी पान इज वेरी गुड, बट वंस इन अ वाइल चलेगा, बट नॉट ऑन अ वेरी रेगुलर बेसिस. एंड स्मोकिंग इज नॉट एट ऑल अलाउड. इवन स्मोकिंग है, ड्रिंकिंग है, ये सारे एडिक्शंस दे ऑल दिस फैक्टर्स. फैटी लिवर होगा, चाहे सीकेडी है, चाहे हार्ट डिजीज है, दे ऑल विल वर्सन योर. So first of all, stop all these addictions. At least reduce, if it not cannot stop at all, at least reduce the addiction of these things. They will benefit you very in a large way.
Uh, we have just a couple of more questions, if you allow us, if you have time. And
Yes.
your CV shows that you are an expert in nutrition, and you emphasize the role of culinary medicine or dietary therapy in endocrine care. So, sir, any tips and tricks for patients living with chronic kidney disease and diabetes? What are the extra things we can do in the kitchen to ensure that our potassium remains okay, to ensure that our serum creatinine doesn't worsen?
Yeah. For those patients, avoid fruit juices. Fruit juices, it is harmful both for your glycemia, your blood glucose levels, as for your kidney disease. It will can increase the potassium levels and also the blood glucose levels. Reduce, take the protein. Your daily protein should be zero point 0.8 gram per kg body weight, not more than that. So restrict your protein intake to that, and avoid nephrotoxic drugs. Many other unknown Ayurvedic preparations or drugs reduce the these painkillers or NSAIDs or another type of like kadha and all. So preparation concoctions wo hai. And take the healthy foods like nuts, green vegetables. And if CKD, you can reduce the amounts of this spinach and sag. They contain a amount of potassium, so you have to take a moderate proportion of these spinach and sag, especially in the winters when they are in abundance, all that. And otherwise you can take the all the good things like uh, protein like dal and chapati and whatever we have, but in moderation. So moderation is the key here. You have to reduce your water intake also up to 2 to 2 liter per day, as per the weather condition is allows. And salt intake, you should also reduce your salt intake also. That will help to protect and keep your blood pressure in control, as well as your kidney damage also. So these are some of the precautions which you can keep in your dietary habits. And increase the calcium intake also, because in kidney patients we have also the dysfunction of mineral metabolism and calcium phosphorus metabolism. So mostly patient, they are having a deficiency in calcium and vitamin D. So we have to take those dairy products and all that who are rich in calcium. So these are some of the tips and tricks which you can use.
There is a specific question regarding coconut water. So, what advice should we give to people living with diabetes, to those living with kidney disease, maybe to those with hyperkalemia?
Yes, for diabetes patients who are not having kidney disease, we can take one coconut water per day. That is not harmful. But those patients who are having kidney disease, it is not advisable at all to take coconut water. It is rich in potassium. So if your potassium level is under control, you can have a moderate or small amount of coconut water if at all you want. Otherwise, it's better to uh, avoid it.
There's one last question, sir, and this is with regards to FDCs, fixed dose combinations. Now, India is known as the home, the capital of fixed dose combinations. Very few people will know, but the first fixed dose combinations in the world were developed in our country, whether it was iron and folic acid, or maybe ibuprofen and paracetamol, or in the diabetes arena, it was fenformin and chlorpropamide. So we are world leaders in this. In the current scenario, sir, in your clinic, how do FDCs help your patients? And if we can
Yeah,
take an
as
example of Dapa-Sita.
yeah, Dapasita, we have discussed the benefits of the FDC of Dapasita, like they are very synergistic in actions and provide all those benefits to the patients of diabetes, and have so many organoprotective effects also. But as for the patient's point of view, it is very good that it reduces the number of pills for the patient and also the cost effective, because in clinical practice we always face those patients who take, डॉक्टर साहब मेरी शुगर तो कंट्रोल कर दीजिए, दवा भी बहुत कम चाहिए और बहुत कम पैसे भी लगे, they all the conditions put for you. So FDCs, they fulfill all these conditions of the patients, and you can cater these choice and conditions of the patients with FTCs. So with the health benefits, they are also beneficial regarding the cost and the number of pills, and increases the adherence and compliance of the patient also. So it is good to have these FTCs.
Thank you, Dr. Alankar. Even I have seen in OPD, the dapagliflozin sitagliptin doses don't need to be titrated. So it's a static dose. So you give that. On the other hand, there are many patients where the metformin dose has to be titrated. Patient may have metformin intolerance. There may be a mimic of metformin intolerance. For
Yeah.
example, diabetic gastroparesis, helminthiasis, a protozoal infection, or lactose intolerance. So while you struggle to, or while you work to titrate the dose of metformin to the maximum tolerated level, you can at least give a static and an optimal therapeutic dose of dapagliflozin sitagliptin while you work around the metformin and get your patient to accept it. So that is one
Yes.
other advantage that we have.
Also, it is to be in once in a day also, no? That is also beneficial.
That's the other advantage, yes. So with this, sir, I'd like to thank you very much on behalf of 4D, that is detailed discussion in diabetes, in dialogue in Indian diabetes, and on behalf of all the doctors uh, from north, east, southwest of the country who are gathered, who are tuned in today. I'd like to thank Dr. Alankar Tiwari for his wonderful talk. And thank you for reminding us that the kidneys are not a poor cousin of the heart. They have the same level. And especially if you listen to Bhojpuri music, the kidneys are more expensive, they are richer, they are more precious than the heart. Thank you, Dr. Tiwari.